So hello and welcome to this ARMA webinar on understanding musculoskeletal health for social prescribing. My name's Sue Brown and I'm the Chief Executive of the Arthritis and Musculoskeletal Alliance, ARMA. We bring together patient groups and professional groups to work for better health services for people with musculoskeletal conditions. We're delivering this webinar today with the support of Arthritis Action, because we believe that social prescribing has a huge amount to offer to people with musculoskeletal conditions. It is the largest cause of years lived with disability in the UK, and many people with MSK conditions also have other long-term conditions. As you'll hear from our speakers, there is so much about managing a long-term condition that causes pain, which is not medical. And this is where we think that social prescribing can really help. So our three speakers today are Wendy Holden, Arthritis Action Medical Advisor and Honorary Consultant Rheumatologist, who's going to give an introduction to musculoskeletal conditions and some of the things that help people to manage their conditions. Then we have Sarah Holden, who is Head of Public Health Services at City Healthcare Partnership, and will give a social prescribing perspective. And then finally, Chantal Irwin, who's Chief Executive of Arthritis Action, will outline the value of patient organisations in this and what they have to offer. So without further ado, I'm going to introduce Wendy and ask her to give her presentation.
Thank you very much, Sue. Hopefully this will be big now. Is that big? That's big. Is that big now? Marvellous, thank you. So a man came to see me the other day. He had knee pain and he wanted some advice on what he could do to help himself. He'd been to see his GP in recent weeks and his GP had said to him, "What is it you want exactly? Do you want a prescription or do you want a sick note?" And that sounds a little bit like a joke, but and obviously that GP could have had a little bit of help perhaps with his bedside manner, but I think it exemplifies the frustration that many GPs have with dealing with people with musculoskeletal conditions, really, bearing in mind that 30% of GP consultations are for MSK conditions. His reaction really just reflected the limited resources that are available in a 10-minute consultation for typical GPs. So that's why I think self-management is so important. And that's why I'm so excited about social prescribing, because this is absolutely going to fill a massive gap for many people who have musculoskeletal conditions. So in terms of my talk, what I'm going to talk about, first of all, is an outline of what are musculoskeletal conditions. I'm going to speak a little bit about the problems that they cause, and then we're going to talk about some of the potential self-management solutions. Okay, so first of all, what are musculoskeletal conditions? Broadly, these fall into three groups. I've put in red the most common of these conditions that you will come across. So first of all, there's the inflammatory conditions, and these are all conditions where the immune system goes wrong in some way and causes potential damage to the joints or the spine or the connective tissues that join us together. So by far the most common one of these is going to be rheumatoid arthritis, and the picture that you've hopefully got on the upper right, the picture has not come out, I'm afraid, the picture on my screen. But rheumatoid arthritis is a condition typically affecting women, mainly often young women. It can affect people at any age, and it causes joint damage if it's not adequately treated. Axial spondyloarthritis typically affects the spine. Often younger people in their 20s and 30s will present with this condition. And then there's a very wide range of other immune-mediated conditions called connective tissue diseases. Again, common, but not as common as the other two. The thing common to most of these people is that they will all be mostly on immune modulating drugs, or frankly, immunosuppressive drugs. And many will have been struggling much more than usual during these last few years that we've been through, because of having to be isolated for very many months and even years for some people. The next group of conditions are ones that are non-inflammatory. So these are different. These are typically what we would call musculoskeletal conditions, or conditions that cause mechanical pain. So there is osteoarthritis, which is often known as wear and tear, obviously more common as people get older. There are widespread pain conditions, for example, fibromyalgia and hypermobility, which often affect young women and cause widespread pain. And then, of course, there's other conditions that don't really fall into this group, such as neck and back pain, often either muscular or sometimes secondary to some osteoarthritis. And usually people with non-inflammatory conditions have pain that comes and goes, or is often worse with exercise. And people with widespread pain, such as fibromyalgia, may well have significant past trauma that's all relevant to their overall level of pain. And sometimes these conditions are much more disabling than inflammatory musculoskeletal conditions, which is often a surprise. The last group of the last condition really is osteoporosis, which is a surprise that this is put into this group, but it's actually probably more common than all of the above that we've just spoken about. It's a silent condition. It doesn't cause pain, but it certainly causes a problem once a fracture has occurred. Now, osteoporosis causes what we call fragility fractures. And what we mean by that is a fracture sustained after a fall from a standing height. So in other words, if I tripped over on my way to the door and broke my wrist, that would be a fragility fracture. Most people do not realize that this is not normal. This is never normal, and it's extremely common. Most of these fractures can actually be prevented. 1 in 2 women over 50 will have one of these fractures in their lifetime. So if you see someone that's had one of these fractures, it's often ignored, including by healthcare professionals, including consultants and GPs. So if you see anyone that's had a fracture during one of these falls, just flag that. It's really, really important. There's effective treatments that can help. So what sort of problems do musculoskeletal conditions cause? Joint pain, stiffness and swelling, obviously, pain and fatigue and poor sleep quality, and difficulties with activities of daily living and mobility. Long-term depression and anxiety. 20 to 30% of people with these conditions will be depressed, frankly depressed, and at least 40% will be out of work. As a result, many people struggle with social isolation. Knee osteoarthritis in itself is actually associated with increased mortality, especially cardiovascular mortality, mainly due to walking difficulties. So this is not just a benign condition. It can be potentially serious. Everything in musculoskeletal conditions is connected. If we have pain, we move less, we sleep less, we have low mood. Often we have to stop work as a result of our pain. As a result of all of that, we can eat more and gain weight. And many people with musculoskeletal conditions are very isolated as a result, because they don't feel like going out so much. One important thing to mention about musculoskeletal conditions and pain is that there is very little connection between having chronic pain and the amount of tissue damage that is actually seen. So looking at this X-ray, obviously the knee on the left-hand side of the picture has got significant degenerative change in it. That's very bad osteoarthritis, but that in fact is a painless knee. It's the other knee that is painful. So it's really important for people with musculoskeletal conditions to know that pain does not necessarily equal damage. This is really important in terms of the language that we use for patients who have musculoskeletal conditions. Many patients will have had X-rays that might show, for example, degenerative change. Many people may have had an MRI scan of their spine, which may well show degenerative change or disc changes, but that does not necessarily mean that that is the cause of the pain. So it's really important that we are very careful in the way that we use language to patients who have joint disease. So there was a very interesting study of patients who had back pain who were referred for an MRI scan by their GP. This was a primary care referral service. And when the results came back, what it was discovered was that only about 14% of those MRI reports were correctly interpreted by their GP. In other words, over 80% of GPs interpreted those results incorrectly. So it's very common for disc bulges to be found in the necks of people who don't have pain. So, for example, 90% of over 50s will have disc bulges in their neck when they have an MRI scan. So these are people who do not have pain. Therefore, the abnormality is not necessarily the cause of the pain. So be careful how we use language, be careful how we use degenerative change in particular. Now, the next point, pain catastrophizing worsens pain. So what that means is if people think that their pain means that there is damage going on, or if they think that their pain means that they are going to become disabled, then the level of their pain will invariably increase. So it's really important to reassure people that sometimes pain is just pain, and it doesn't necessarily mean that there's a disaster going on. Self-management, learning self-management and learning the importance of these skills can really, really help to break this vicious cycle. Now, these are the aspects of self-management that I'm going to talk about. So each of these topics is a whole webinar in itself, so I can only really cover these very, very briefly. I'm going to mainly focus on exercise and weight management, but I just wanted to touch on this issue of education, because a very important part of self-management is education and helping people to help themselves understand their condition. And this issue of low literacy, low health literacy, is a really, really hidden disability. So 1 in 6 people that come to see us will have very, very low literacy skills. The average reading age of somebody in the UK is around about year 6, so that's the average 11-year-old. But these people with low literacy, about 18% of the population, will be reading around about a year 1 or 2 level. So they cannot navigate medical information. Most of the medical information we provide in written form is not at all accessible to them. And these are people that potentially have the most need for our skills. So it's quite difficult to spot these people sometimes. Sometimes they will be people who will be upfront about this. They will say they've got dyslexia, for example, but other people are very embarrassed about this problem. They may be people who forget their glasses so that they can't read information. But a simple way of identifying these people is to just ask them, do you have difficulty with understanding medical information? It's a really simple and non-invasive way of tackling this problem. Now, why is it really, really important to think about weight? Now, I've put this as number 1 important thing, because I think this probably is the most important thing really when talking about self-management and MSK conditions. Now, I am not a big favour of fat shaming at all. I am very against fat shaming, but the fact is that being overweight seriously increases the risk of many types of arthritis and makes it all worse. So not only does being overweight increase the risk of osteoarthritis, it worsens joint damage and increases the level of pain. Being overweight is a pro-inflammatory condition, causing inflammatory chemicals to flow around the body, which again are harmful. That increases the risk of cancer and heart disease and can cause generalized pain. Joint replacements will fail. In inflammatory arthritis, medicines for arthritis are much less effective. And for every kilo of excess weight that we have, 4 to 6 extra kilograms goes right through the joints. So it's very, very important that we tackle this issue. Obviously not at all easy to do this. Now, I use this picture to illustrate really what I see as a personal disaster, really, what can happen if we don't tackle these issues. So this fella, obviously a big person, and he's somebody who hasn't been able to work for many years because he's huge, frankly. He had a knee replacement after losing a lot of weight over the course of about 6 months, but unfortunately after the operation he had some pain and some complications and was unable to mobilize, so he took to his wheelchair. His wife, who's a very thin person, a very caring person who likes to feed him, very rapidly fed him up, so he regained all or more of the weight that he'd lost prior to the surgery. And the first time this poor fella starts to try to stand up, he'd broken his tibia there, the big bone there. So this poor fella is going to need more surgery and will probably never walk again as a result. So this just kind of exemplifies really the problem of weight. This was never really tackled in a holistic or a sensitive way for this man who's depressed and he's got lots of other issues contributing to his overeating. And I think a fact that many people don't know is that being on a diet is a serious risk factor for gaining more weight over the next 5 years. Most people who are on a diet will gain all of their weight over the next 5 years because it's a very multifactorial problem. Now, the good news about arthritis is that you do not need to lose very much weight in order to reduce pain dramatically. So even if you could only lose 5 or 10%, you know, for many people, that's maybe about 10 kilos of weight. Most people can do that. But it can significantly improve pain. So it can improve pain by as much as 30%. Joint replacements might not be needed anymore. It improves mobility and quality of life, and even better, inflammatory arthritis can be better controlled as well. Now, all the guidelines for dealing with osteoarthritis include weight management, but it very, very rarely happens. So obviously surgeons have probably even less time than a GP to say to somebody, perhaps you need to lose some weight, but that's about as far as it goes. There's no advice on the more holistic way of doing this, and it requires a lot of input and a lot of sensitivity and a lot of education to help people understand how and why they're eating unhealthily. Now, in terms of diet and arthritis, there aren't any foods that worsen arthritis or actually cause arthritis. Now, this is a common misperception and perpetuated by the internet, who say avoid tomatoes and avoid red peppers and things like that. There is no food that is actually pro-inflammatory. Being overweight, as I said, is pro-inflammatory, but no foods are bad for arthritis. Lots of people think that certain foods worsen their pain, which is not unreasonable, I guess, if they have that strong belief. I can think of a patient of mine who swears that lamb chops are very bad for his arthritis. Fair enough. And if he believes that avoiding lamb chops will help him, that's absolutely fine and good for him. What we know about diet and arthritis is that in general, a healthy Mediterranean type diet with lots of fruit and veg, pulses, generally low fat is going to be the way to go, because that's a healthy eating diet with lots of helpful things like omega-3 fish oils, for example, which can definitely help with inflammatory arthritis. So you don't need to avoid any particular groups of food, just try and aim towards more healthy eating. There are no particular food supplements that help with arthritis, except for some evidence for omega-3 fish oils in inflammatory arthritis, and vitamin D for most people in the winter where we don't get enough sunshine through September to May. There's absolutely no evidence that any supplements like glucosamine, chondroitin, or turmeric, although it's very fashionable at the moment, will help in therapeutic doses. If you ate enormous amounts of turmeric, potentially that could be anti-inflammatory, but at normal doses, definitely would not. Now, in terms of exercise, this is also the most one of the most important things in self-management. I just wanted to add a little PS on this one. People who have fibromyalgia and pain secondary to chronic fatigue or hypermobility probably shouldn't be doing progressive exercise, because it almost always makes them worse. They should be doing something called pacing, which is a different subject, and you will need to read a little bit more about pacing. But for the vast majority of people with arthritis, exercise is the way to go to manage joint pain. So obviously, if it hurts to move, then we tend to move a bit less. Of course, it's just kind of common sense. It feels wrong if our knee hurts to keep exercising, but that in fact is exactly the wrong thing to do. Most people will come to see a healthcare professional and say, is it going to hurt me if I exercise? Or when you encourage them to exercise, they know, I'm scared of damaging my back, or I'm scared of damaging my knee. So fear of exercise is a really important thing to tackle, and you have to reassure that you can't damage your joints by exercising. So even if they're swollen, there's good evidence that for example, during a flare of rheumatoid arthritis, there's good evidence that lifting gentle weights can really help, obviously within sensible limits. The counter to that is that not exercising will always harm the joints. So as soon as we stop exercising, as soon as we rest, those muscles will start to get weaker around the joint. There will be less support for the ligaments and the tendons around the joint. The joints will become less stable, and then they will be more painful. Now, the great news about exercise is that it really, really, really works. So exercise in itself leads to the production of anti-inflammatory chemicals in the body, which is brilliant news. Can calm down swelling. Tiny amounts of exercise can really help with joint pain, and even just doing quadricep strengthening exercises can reduce pain by as much as 30%, which is as much as codeine. Resistance exercise, that's exercise to weights, will improve strength at every age. And weight-bearing exercise can help with bone density. Now, a really interesting fact is that just having a step counter or even a phone in your pocket, just having it on you, can increase your daily steps by 4,000, which is very, a massive, just by having a counter. Now, exercise doesn't need to be traumatic in any way, as long as we are doing a little bit more than we were doing before. Now, obviously, if people with arthritis are exercising, they probably don't need our help in the first place. So we're talking really probably about mostly hardcore non-exercisers here, who may be doing little or nothing. So anything that we can do to get people moving a bit more is likely to help. And what we would tend to say is for them to try something that they would enjoy, something that's fun, and something that they can keep up. Obviously, most people are not going to want to dress up in Lycra and go down the gym and join a high impact class in a noisy exercise environment, but classes in community centres and exercises that you can do at home, all very, very valid. Doesn't have to be expensive. See these fellas in this picture here, some of them wearing their outdoor shoes, so don't even have to get any fancy equipment. Yoga can be done sitting, as can Tai Chi, as almost as good as standing up. Now, there's a great study that is extremely powerful, where there was an 18-month study of people who had supported exercise and supported dietary advice for 18 months. These are all people with knee osteoarthritis. And the great thing about this is there was a long follow-up. 18 months is a long period. And after 18 months, 40% of these people who were potentially heading down the road for surgical intervention had no pain after 18 months, which is remarkable. Reduced levels of inflammation in their blood and better quality of life. People who are pain-free can now get up and about and move. And the really great thing about this study is that up to 60% of the group continued their endeavors after 18 months, which is a fantastic result. Most people joining the gym now will quit by February. So one of the key things may well be group exercise. So if you've got that in your area, that is a really, really powerful tool. Now, just a couple more things I wanted to mention. So most people with arthritis will struggle with fatigue. Fibromyalgia has fatigue as one of its definitions. And it's often the worst thing for many people with inflammatory arthritis and joint pain or all MSK conditions. Nearly 90% of people with rheumatoid arthritis experience severe fatigue at some point in their life. And for any of you who've had fatigue, linked to COVID, which I certainly have, it was absolutely horrible living with chronic fatigue for more than a day. It's awful. Fatigue is a multifactorial thing linked to pain, linked to bad sleep quality, linked to mood in menopausal women, linked strongly to hormones, which can also cause joint pain. Strategies are complicated, but there's some useful things you can do to improve sleep quality called sleep hygiene. Mindfulness can definitely help, especially mindfulness meditation and CBT can be helpful as well, and gentle exercise and getting some daylight as well can definitely help with sleep and fatigue. Similarly, people who have living with chronic pain are often low in mood. It's exhausting to live with chronic pain, and they often say they are sick and tired of being sick and tired. And I think this is also importantly linked to the fact that many people worry that they've got progressive damage going on in their joints. And as I said, sometimes reassuring people that they don't have progressive damage is helpful in itself and can lift people's mood. Once we become low and anxious about going out, then we become more tired and we become socially isolated. So all of these things are intimately connected, and Sarah's certainly going to touch on those things in a minute. Now, in terms of mood and arthritis, it's very important, of course, to keep an eye out for those people who may well be properly depressed and whose mood can't be lifted, so they may well need some medical support with that. Social prescribing is very, very exciting, I think, because it's obviously there's lots of strategies in there to reduce social isolation, which I think are really, really vital for people living with MSK conditions, and good evidence that exercise can also help lift mood slightly. Talking therapies, sleep and distraction can also help. And more recently, just in the last month, actually, a study of mindfulness meditation called MBSR, performed over 8 weeks, can significantly reduce anxiety. So another useful tool, and there are free resources online to do 8-week mindfulness courses. So I think that was all I wanted to say. How did I do with the timing there, Sue?
Not too bad. Thank you very much. And I think you will all be able to see from listening to that where social prescribing will fit into supporting people around all of those things. Lots of things that are amenable to social prescribing support. I'm now going to ask Sarah to come in and just give a little bit of practical examples of how this works in practice.
Thanks, Sue. Good afternoon, everybody. Hopefully you can see the screen and the PowerPoint's popped up in front. So yeah, good afternoon, everyone. My name's Sarah Holden and I'm Head of Public Health Services in the Northwest for our wellbeing services in St Helens, as one of the services that I'm going to talk about today. In terms of sort of the presentation slides, really it's to just think about the benefits of social prescribing. I think I just acknowledge that social prescribing has various different models and different ways of delivery of social prescribing across the country. I can see quite a few people have introduced themselves in the chat this morning, and we've got some social prescribing link workers on there, so hello to you all. I'm going to talk about how our social prescribing link workers are embedded within our wellbeing services in St Helens, and how that works for both the benefits of people, partnerships, communities, and touch a little bit on the financial side as well. So the wellbeing services that I'm talking about today are really a range of different health and wellbeing interventions that you can see sort of the links really between the previous presentation, thinking about exercise and nutrition, about healthy weight, about oral health, and all of those different combinations really depends on who you are and what you need when you come through to the service. And what we've done is we've built social prescribing as an approach into all of these services. And depending on your needs as a client, sometimes it's quite simple. It's about a navigation and signposting somebody onto the relevant service in their local area that they already know they'd like to access. For others, it can be really complicated, and that could be a mix of mental, social and physical complexities that might take some time for your link worker to work through with you. Certainly the cost of living crisis, the COVID pandemic and many other things affect and challenge people within our communities, and health inequalities is something that we're really passionate about trying to make a difference. So those who are perhaps most removed from services and least likely to access, we are providing support for people within those areas and trying to shape services working with people so we understand what the needs are and then shape services to be able to support them for ensuring accessibility and use of services in the local area. In terms of how we sort of provide our social prescribing support, we split it into 5 different domains. So this sort of gives an idea of sort of the areas that social prescribing can cover. The way we look at it is thinking about what sort of financial support and advice somebody might need, what sort of housing support, education, learning, or whether you want to get back into work if you've been out of work, or perhaps may have lost your job as a result of perhaps the pandemic, various different scenarios. We also think about then what activities are out there in the community that will boost social well-being and reduce isolation, and that's so varied across the patch. And then we also then think about the health and the well-being side of things and think about what sort of activities somebody might need. to improve their physical health and mental health and well-being. We overlay that with theories and principles, and we think about the 5 ways to well-being within that as well. So thinking about giving you time, being active and connecting with others, things like mindfulness and taking notice, and continually learning, whether that be educationally, new skills and hobbies, etc., are all really good approaches to having good mental health and well-being and keeping well in the long term. So we think about that in terms of the approach that we take as well. So very briefly, for our social prescribing approach, it is a very much a holistic approach and thinking about the individual that sits in front of you or rings up and has a chat over the phone. So it's about what's important to the client as they come through. It may be they come from on a referral basis from their GP. It may be that they've attended an event in the community, but it's really about sitting down and just understanding where that person's coming from. It underpins whichever service that you go into within the wellbeing services. So what we're talking about here is seeing the person, not just a condition or a reason for referral. It's about empowering that person to take control and to make decisions by helping them to navigate the system, the services and the information that's available to help them manage a condition, to help them to be able to access housing advice or benefits advice or whatever it may be for that individual. And I think really it's about getting that wider, some of that stuff that happens in life, some of those challenges or many challenges in some cases that people face, trying to help people to get that stuff sorted so it feels manageable. So that gives them time and space to think about some of the other things like getting active, perhaps losing weight and other things that can benefit their condition. In terms of the actual programs that we offer, under our exercise bubble that you saw on the previous screen, we've got a range of specialist exercise pathways. One of them is the MSK Escape Pain, and I saw some information again in the chat earlier about somebody mentioning that, but we run a program in the area working with our physio colleagues so people can actually go through that program and receive education and exercise advice that helps somebody to overcome some of those fears and myths perhaps about exercise and obviously raise the benefits of that as well. We also run a range of other physical activity programs ranging from gentle Tai Chi classes, circuit-based training and interval training, healthy walks, getting out in the local area and in nature, which has multiple benefits. And then we work with our partners as well and linking with local leisure providers so people can access those at discounted rates. But ultimately, we're listening and looking at what and who could help the person and put them in touch. So I'm just going to talk very briefly about the benefits at an individual level. And this is just a couple of examples of many people who go through the programs to give an idea of the sorts of people that might come through to the program and how they are benefiting, what sort of measures we take as part of that. So Mr. M was somebody who was extremely isolated with extreme social anxiety. He did have debt problems when he was referred to the service and very much overwhelmed. His issues while he was presenting into primary care were very much around social side of things and really a prescription wasn't something that was going to support this individual. So they came through and saw the link worker. We take a number of different measures as a baseline to help us to track progression and see how people are improving on the programme. So their wellbeing score was significantly low and the depressive symptoms using the PHQ-9 was extremely high. So with this particular case study, it was very much about taking time, and I appreciate in different programs of social prescribing do deliver differently, but we have a very varied approach to that. So you can stay with the program for up to 12 months. So this individual was about building up time and trust with the person. Eventually they were referred into mental wellbeing services and our Think Wellbeing program locally. But they had a joined up care plan with our health trainers within the wellbeing service so that we weren't duplicating different care plans and making it confusing, and the practitioners were speaking to each other as well to be able to support the individual with their goals. They had some focused techniques around anxiety management built into that programme, which helped, and regular calls from the link worker. And they fantastic to see that that person was actually able to leave the house for very short walks after maybe about 12-14 weeks of working with their link worker. And that might sound small to some people, but it was significant to that person who hadn't been able to leave their home. The 12-week scores were showing some improvements, but we recognise that this client needs a lot more support, and they're getting to their 6-month programme now, and actually the signs are still looking really positive for this individual. Ultimately, they said they felt like they had the right support and the right people around them to support them, and things were starting to slot into place for this individual. So it was absolutely a journey, and will continue to be for this person. The second person was a lady who was a working lady who was in significant chronic pain, so was struggling really with staying in work and having quite a lot of time off sick. Again, her well-being was particularly low, and PHQ was high again. So it was around not just thinking about the physical side of this, it was very much about what impact it had on from a mental health point of view as well. In this case, her link worker signposted her into ACAS for employment support, so getting the support from the experts. But she also supported her with a PIP application and applied for a discounted membership to the local leisure centre that she wanted to have a go at. Again, significant improvements seen from the individual's point of view at the 12-week review. So seeing improvements in the wellbeing score and the PHQ-9 score coming down. Really, what she got achieved from the programme is that regularity of exercise and being active to manage her pain, that she did get through that process of working with her employer and with the support of ACAS to be able to get an arrangement that worked for her in work, and she did get a standard mobility rate approved on her PIP application as well. I think with this lady's feedback, it was about really not knowing where to go and navigate for how to navigate the system and how to get the right support to be able to help to move forward. So it was absolutely crucial for her that she wanted to keep working but couldn't see a way forward, and sort of having that regularity of support and calls made the difference to keeping her going, and she's regularly being active, which has both physical and mental health benefits as well. I'm just going to touch slightly on the escape pain programme specifically, but this is, as I said, one of many physical activity pathways that people can go through, so isn't necessarily suitable for everybody, but certainly for those who are coming through the MSK pathway, then this is something that we are capturing the measures for. So as you can see on here, improvement scores across all those 4 domains of improvement in pain, in function, in quality of life, and the mental health and well-being through the SWEM-WEBS measure. So all of those showing an improvement. In terms of our retention rate as well, we felt that that was something that was a real success of the programme, with 94% of the clients being retained for the duration of the course and continuing to go on to do something else at the end of the programme. So with all of the pathways, it isn't about coming to the end, it's about continuation of behaviour changes and building that into lifestyle as part of the success of the programme. So that's something that we just wanted to share a little bit with you. So if we just turn to think about the benefits for our communities, just to say really there's multiple benefits to having social prescribing within the communities. Our link workers and our wider team are continuously mapping across the patch to look at services. Things change, new services come along, new funding streams come on board, new community groups get set up. So it's a continual piece of work to continue to map and also hold that within a directory, so that we can be that navigating support for local people if they need that extra hand of where to go and who might be able to help. The service has mapped over 350 different services so far, and again that goes across the domains that I mentioned earlier on in the presentation. So navigation is really important because sometimes it's like, where do you start and who can help me? Certainly it's also about making connections and bringing those communities together. So the points on there really are about identifying what the needs of local people are. So when we're working with our communities, we talk to them about that, we engage, we look at if we can map and find something for that person to be able to join. But in some cases it does spring up that there's gaps, or there isn't any support. So where we can, we're working with our community itself to develop new activities. We may be seeking funding to set things up. We'll be working with our third sector colleagues and others to be able to look at who can, if anyone can support the programmes of work that might be needed for that local area. And we've also seen some really positive stories about people who felt empowered, who built their confidence, who are now taking on board more of a volunteering role in their local community, either as a voice of somebody who's been through that programme, who can encourage others to get involved. So that peer-to-peer support has been really important. And in some cases, people joining groups of their own interest, their social activities, and getting more involved themselves. So absolutely benefits are multiple for our communities. In terms of partnerships, our partners are very wide and varied, but just a few examples on here. So our link workers...
Just quite quickly, if you can, Sarah.
Yeah, our link workers are very much embedded within practice teams. We're working with secondary care and our mental health teams. So really just about joining that care up, as I showed in the example, working on that one-to-one basis earlier. And then finally, benefits from a financial point of view. So just thinking about sort of what the costs of social prescribing can bring to local communities. So we're fortunate enough to have social accountants that work independently from our company, and they look at a wide range of evidence. So this year they've looked at all of that and have deemed for every pound that's been spent on social prescribing is a £45.74 return on social value to the local community, which is fantastic to see. And finally, just to talk about the escape pain programme, so just over £43,000 of savings to the health and social care system based on only 29 clients who were evaluated through the Health Innovation Network for one of our programmes. So again, fantastic to see those savings that can be made to the system. And that's it. So very whistle stop, but hopefully get a flavour of some of the benefits from the social prescribing being embedded within our programmes. Thank you very much.
Brilliant, thank you very much. And leads quite nicely into our final very brief presentation from Chantal. One of the things that ARMA is extremely keen on is making sure that anyone who has an MSK condition is in touch with appropriate patient support organisations, because they have so much to offer, and do not assume that because someone has seen a clinician they know which support organisations are out there. So Chantal, if you want to give a brief overview of what sort of things patient organisations can offer.
I'd love to. Thank you very much, Sue, and thank you for having me today. I'm the CEO of Arthritis Action, Chantal Irwin, and I'm here just to remind everybody that charities are here, patient organizations, to support you all and to support the patients that you are going to come across and work with. So I'll give you a brief introduction to our services so that you know what we do, in the hopes that we can help as well. And I know Sue will mention our other friends in the sector who also do a lot of great things and services to help. Arthritis Action, we've been around for over 80 years supporting people and with the self-management approach. So essentially we're a UK charity and we want to help people live fuller lives with less pain. And we do this with a self-management approach. So I will let you know some of the services that we offer. And really our goal is to help people gain knowledge and confidence to best manage their condition. So our self-management approach focuses on both the physical and mental impacts of living with chronic pain and with musculoskeletal conditions. We all know that one size does not fit all, so it's extremely important for us to offer a range of services and a range of different ways that people can learn so that we can support them living with musculoskeletal conditions. We are a membership organisation, and our membership costs £20 a year or £15 by direct debit. So there are a few services that we offer that are solely for our members who pay. These are listed here. I'll just quickly go through our nutritional and weight management consultations. We have 2 subsidised appointments to go see an osteopath and a physiotherapist. You can come along on priority bookings to our groups and to our events. And then you can also work directly one-to-one with one of my team who helps people set goals and then achieve those goals. We have magazines, and people can come along to our annual conference where there's a range of great speakers that help them again continue to learn, to support themselves. We have a volunteer-led Connect service. Peer-to-peer support, as we know, is extremely important. So they can do that either through Arthritis Action Connect or the online groups that we run. And we also run an online exercise class that helps people to gain strength and confidence in exercising so that they'll hopefully go on and continue to exercise or do activities that they enjoy on their own once they have that confidence. But we do not want costs to be a barrier to supporting people. It's really important that we work with as many people across the UK as we can. So we do have a number of services and resources that are free to the general public. So I'll make sure to tell you about those today as well. You can see here our lovely Martin, who's our registered dietitian on the team. So he does work directly one-to-one with individuals to help them gain support. This is really important. As you know, if you Google diet and arthritis, it is extremely overwhelming. So actually, he gives a lot of support to people, answers a lot of questions about supplements as well. And again, through the free resources, you'll see this common theme on all the slides, our web pages, fact sheets, FAQs, webinars, podcasts, and videos. There are a lot of different resources for free. We also can send things out by post and print them for people if they do not have access to the internet. So again, we want to try to support people in many different ways. Exercise, I mentioned the online exercise classes members can do, but we also have a lot of free resources up on the website. So you'll see our chair-based exercises to get people started. We signpost people. We have an exercise and activity directory. So we list activities around the country so that people can look into their local area and see what's available to them. And we work with a lot of partners to deliver that. So I see Escape Pains here, which is great. We work with Escape Pain. We're currently working with the Move Together app, Good Boost app, to get people exercising. So we host sessions, and we're currently in a project that's training 100 leisure centres around the country about feeling confident to work with musculoskeletal people with musculoskeletal conditions. So we hope that will continue, and you'll have some leisure centres in your local areas down the line who will have that confidence. Also on mental well-being, again, a number of different ways and through our webinars, podcasts, and videos that we support people with mental well-being. And also we have a mental health directory, which is the same as our activity directory, so people can get support in their local areas. We also are working with many IAPT services around the country to help train them on living with musculoskeletal conditions so that they feel confident supporting people as well. And then general support. So you can see here our young adult hub listed. So again, we have a separate area for young adults working or living with musculoskeletal conditions. And then lots of information on the things we get asked the most, from cost of living and disability and benefits and work in arthritis through to medications and communicating with your health professional. So finally, as I mentioned, for anyone in the country can come along to our events and to our online groups. They don't have to be members. We want to be supporting them, and peer-to-peer support is so essential. So people can join our groups. They can listen to our webinars, come along to webinars, podcasts, our self-management events, which helps people learn about pain management. And we also deliver a range of presentations around the country as well on either self-management in general in arthritis or specific topics they're interested in learning about. So again, it's really key. Please do get in touch with us if you'd like to join our online group to learn more, to meet some members, hear their stories. Please do look in your local area in case our friends are running local support groups on the ground there, or we can come along and present to you or a group of linked workers or your patients if they have specific questions that they would like answered. So that's it for me, a whirlwind tour, and we do hope that you'll get in touch, and we do hope that we can continue to support all of the people that you are helping. Thank you.
Brilliant. Thank you very much, Chantal. And that's one example of the sorts of things that patient organisations can deliver, but there are a whole range of patient organisations, and I would really encourage you to find out what's available in your area locally, but also to bear in mind that a lot of these organisations do have, as Chantal said, the Facebook Lives, the national things that people can access. They all have slightly different things to offer, so do kind of check out the range of things, because some people may find it, and some people may find it helpful to be in touch with more than one organisation because they are providing different things. So, you know, Versus Arthritis, which is our largest member, they have all sorts of local services, but they also have a 24-hour chat bot who can deal with some of the common queries 24/7 via their website. The National Rheumatoid Arthritis Society has some quite structured self-management support for people specifically with rheumatoid arthritis. The National Axial Spondyloarthritis Society local groups are supported by physiotherapists. The Ross Helpline is specifically run by nurses. So most of these organisations have local groups. Most have online events, and quite a lot of them also have helplines. So do check that out. And in fact, the guide we produced for social prescribers, which I'll pop in the chat box in a moment, that lists most of these organisations and their contact details and what they provide. Also, don't forget children. Children get MSK conditions as well. The CCAA is specifically a children's organisation, and both National Rheumatoid Arthritis Society and Versus Arthritis have specific services and support for children and families. So I would definitely encourage you to check out what's available in your local area, and also what might be useful to some of your clients that is available nationally. So we now have a tiny amount of time for questions, and we have quite a few popping up in the chat. There's one here from Ian, who is in the process of setting up some sessions to support people with long-term conditions, make positive lifestyle changes, get fitter, manage their long-term conditions, etc. And the question is, what are some of the MSK related issues we should primarily think about focusing on for an MSK cohort? The thing I would add is, don't assume that the people who haven't been referred for an MSK condition don't also have an MSK condition, because an awful lot of people do. But I'm wondering, Wendy, if you've got any advice of things to think about who's doing this sort of self-management.
Yeah, it's tricky, isn't it? Because you've obviously got to prioritize things, haven't you? And I would say, in terms of effort put in to benefit out, improving things like mobility for older people is really important. You know, giving them quadriceps strength so they can get off the loo and be more independent is incredibly important. So I mean, that's definitely worth focusing on, and often that can be taught in a group setting, so it's quite easy, and they don't have to do much to improve their strength. 2 to 4 weeks is plenty. Weight management is obviously a bit more long term. So, however, that's where the bulk of the effort should go, I would say, as well.
Great, thank you very much for that. Just having a quick look. Down, and there's a question here which comes up a lot. Plenty of over 80s that are only just about getting to grips with texting, so online is not accessible to them. I would put a word of caution in here of not assuming that over 80s can't do online and under 80s can. Lots of young people have don't have access to the data needed to do some of these things. Plenty of over 80s are more than capable of joining something online. So don't try not to make assumptions about this, but yes, there are lots of people who are excluded from online things. Don't know if any of our panelists have got any advice about how to tackle some of that. Anybody want to come in on that?
I don't mind. So
Go ahead,
a little bit, just very quickly about, I suppose, what our experiences working with local communities. So for some, it is about understanding, like you just said, it's not always about whether you can do online or not, but if you can't do online, you need to be out in the community. So either you, or if you can't do it in your role, who is the partner that can do it, and work with that partner, because they'll be able to give you lots of info and ideas of, you know, how to kind of join it all up. So I think there's something about partnership working for sure. You know, thinking about local housing providers and people like that who might be able to help as well. So just reaching out to your community if you can, or your partners if you can't directly do it. It's probably some good advice.
I'd add to that too, Sarah. That's what we do at Arthritis Action. We go out and do these presentations with community groups that already exist and have their membership base, so that we can reach more people who potentially wouldn't be accessing our services online. But we also do telephone groups and telephone services for those who don't want to use tech or can't use tech.
Great, thank you very much. And then I think we've got time quickly for one last question. So this question is about people with, quotes, chronic pain. So if you've been told you've got chronic pain, but you don't really have a diagnosis, what would your advice be in terms of, is this sort of thing we've just been talking about appropriate for people who just have chronic pain with no diagnosis? Wendy, what are your thoughts?
Yeah, definitely self-management is important for people with all conditions. I think I would just be cautious with over-exercising too much, which can sometimes make chronic pain worse. Pacing is very important. There's lots of resources online. So for example, Explain Pain, there's a very good video explaining chronic pain by a guy called Lorimer Mosley on YouTube. That's definitely worth looking at. And I think it's important to understand sometimes that pain does not have an obvious reason. That's also important. Many people with chronic pain will not necessarily have a reason for their pain, and it's multifactorial. So that's often the conclusion that investigations will come to. So keep going, I would say, keep going.
Brilliant, thank you very much. So we've come to the end of our hour now. Thank you all very much for joining, and huge thanks to our three presenters for contributing your advice. As I said, this webinar will be available online. Please do share the link when we send it to you, and do also check out the written resource pack that we produced for social prescribers, which very much works alongside this webinar. So thank you all very much for joining.